Yeah, so hello everyone. Welcome to Azim Premji University's Friday colloquium series. My name is Nazrul. I am very pleased to have Dr. Johnny Oommen with us today to talk in this series. It's a pity that we are not having Dr. Johnny in person because whenever I have met him, there's always a sense of compassion I observe in Dr. Johnny. And there's always a restlessness in him to do something new, to keep on doing something good for others. And there's a reason for it. Dr. Johnny and his wife, Mercy, they have been working in a very remote place called Bissamcuttack. Bissamcuttack is the place in the district Rayagara, just next to Kalahandi district, surrounded by Niyamgiri hills. And they have been working in a medical hospital called Christian Hospital Bissamcuttack, CHB. And the work started as medical practice, but gradually they realized that this hospital is actually predominantly serving tribal population of around 200 kilometers radius of more than 52 villages. So they realized that health is not the only need. So their work started with health, then progressed to providing education. They started working for community empowerment and so on and so forth. So Dr. Johnny and his team lead an extremely busy life. And I have been to his hospital, I have been to his place, I've stayed there. And his hospital is a very unique place, the CHB. I think one reason is that they can't refuse anyone there because everyone comes with acute need. Everyone is from marginalized background and they don't have any other good hospital, good medical facilities to go. So you can see patients being treated by very good doctors. Families are, in fact, the next to the patient. They're preparing food for themselves as well as the patient and others. So lots of activities are going on at CHB all the time. And everything is done with a sense of healing, not only treatment. I'm sure Dr. Johnny will talk about that. So during when this pandemic started and some of us were involved in COVID response in Bangalore. Our university is in Bangalore. And we have seen how hospitals in cities and in Bangalore are working. Because the nature of the virus is such that it needs lots of isolation, lots of protocols to be maintained. So we're wondering that how a hospital like CHB, how Dr. Johnny and his team is managing, how are they dealing with this pandemic in this time? So I would request Dr. Johnny, and thank you, Doctor. I would request Dr. Johnny to share your stories. What is it about responding to this pandemic from a very rural, remote hospital? And I'll also request the audience to type your comments, questions on the chat box. We'll have enough time for discussion because Dr. Johnny is not going to take much time. We'll have discussions more after his talk is over. Over to you, Doctor.
Thank you, Nazrul, for that introduction and for the invitation to the university and into the family of APU. I had actually been there as a parent when my son was studying there and had planned to come in March, but the lockdown shut us down. So it's really good to be able to meet you, though I would have, of course, loved face-to-face. This is the only option right now till COVID decides to back off. So we have time together, and what I suggest we do is that first I'd like to show you a short 10-minute movie about the hospital, which will give you the background kind of understanding, the picture of the context from which the thinking is coming. And then after that, I'd like to take you to a presentation on how we have been trying to respond to COVID here. This is not rocket science. We are not unusually good people. We are just ordinary people trying to do the best we can in the circumstances. And then we'd like to throw this open to questions. So please keep your questions, please put in your questions, and don't worry about being rude and all that. That's perfectly okay. Whatever you'd like to ask, please feel free to ask through the chat box. Let me just begin by asking Bakul to please, can you screen the movie from Bangalore? It's safer that way because I'm not technologically very strong. I'm still the wrong generation. So if Bakul can show the movie, and then we'll move on with that. Thank you.
I think they will play it again. There's some problem with the sound. Bakul and my colleagues, Bakul and Prabina, is actually supporting us from behind. Can you just play it again with sound, Bakul? Yeah, so she's saying yes. So
Sure.
they're going to do it.
There's no fun in life unless there is a glitch somewhere. So don't worry. That's perfectly okay.
But your film has a very interesting name.
So this is an interesting film. Actually, we got inspired by some of the staff of APPI who are posted very near us in Muniguda, who kept saying this is too good a story not to be told. Okay, here it comes, I think.
Yeah.
Our primary focus is always the poor, the needy, the marginalized, the vulnerable, those whom society does not prioritize on. Christian Hospital Bissamcuttack is a hospital, but it is not just a hospital. This hospital was started in 1954. The location is strategic in that this is the region that has one of the worst health status in the country. We are on the junction between Kalahandi district, Kondhamal district, and Raigada district. Of the population of this district, 55% are from the tribal community. The predominant community here is the Kui Kond community, which lives in 315 villages of this block. In 1954, a lady doctor from Denmark, Liz Madsen, decided to come out here. She had read about this region, a region where people were dying and there was no healthcare available. She sold her practice, came to India in 1953, starting a small clinic where she could respond to patients coming into her. By 1975, we were 40-bedded, overflowing. but the hospital was facing impending closure because there just wasn't the resources available. At this point, a surgeon from Chhattisgarh, Dr. Virendra Kumar Henry, and his wife, an American nurse, Nancy Henry, moved to take over this hospital. They took charge in 1976. They rebuilt, restructured this hospital to be self-sufficient, to be able to run on just what the patients can pay. We do not charge anything for registration. We don't want any patient to have to pay before seeing a doctor. Some may not have anything with them. CHB is a community hospital. Our gates are never closed. We do not limit the number of people who can come with a patient. Especially the poor tend to come in large numbers with families and relatives. We allow everybody to come in. Patients and families cook together. They provide their own food. We have to have spaces, garden spaces where they can sit together, because healing is much more than cure. It's much more than just operating or giving medicines. Healing is best when the family is with you. We do over 6,000 surgeries a year, which divided by 365 comes to 17 a day. A little over 4,000 deliveries a year, many of whom are referred from government hospitals. This is the only hospital of this capacity within a radius of around 200 kilometers.
Ones who receive the patients in whatever condition they are. Whether they walk in or come in on a stretcher, it's the nurses who take them in. They do all the initial assessment, most of the initial treatment, and then they call the doctors in. And their competence levels are very high.
In 1978, with a 2-year A&M training program. In 1996, we upgraded, and this year, 2018, we have opened a College of Nursing with a BSc Nursing program.
माने कस्तूरी कुसलिया मोताडिंग पाइरो आसीछि जे माने कि लैंग्वेज भी बुझी पारंती नै बहुत भाबे पड़े जंती कि तांको कोन हो जे तांके कहि पारंती नै हेल्प कला पर जंती कि हम पेशेंट को हेल्प करू थ्रू द गॉड हमको सेंड करछन जे हम मन को हेल्प करि पारबो जंती हम हेल्प भल लागे.
We give them the best education possible at the lowest cost of their districts, their communities. For us, nursing education has been the flagship of all our training programs. The dream is health for all. a day when everybody can live with dignity. CHB's MITRA team engages with the people of 53 predominantly tribal villages. Health centers, nurses living in the villages, visiting each village twice a month. They build relationships with the people to be able to look after their own health. The infant mortality rate was 201 to 29. And what is most satisfying is to see children from these all.
I think there was some problem. Yeah.
Yeah, so I'm sorry, some glitch there. Shall I just try from this end, from where we left?
Yeah. From the work of Mitra, I think you can just screen it again.
Sure. She said, you're on screen. Click on it.
You have to allow the audio also.
Only audio, no? There's a checkbox for audio. Let's just do it and see. Just tell me if it's working, huh?
Yeah. Yeah, very good. Nice.
Is that okay? The dream. Everybody can live with dignity. CHB's MITRA team engages with the people of 53 predominantly tribal villages. We have 2 health centers, nurses living in the villages, visiting each village twice a month. They build relationships with the people. They do health education to try and empower people to be able to look after their own health. The impact is visible. In 1995, the infant mortality rate in these villages was 201 per thousand. In 2017, it had dropped to 29. And what is most satisfying is to see children from these villages, now all grown up, studying, training in our hospital, and coming back to serve their communities and their people. Education is the game changer in rural and tribal India. One of the initiatives that we began in 1998 is the MITRA Residential School, Kachbaju, an Adivasi school, operated and managed in partnership with the people of 16 villages. It is rooted in the Adivasi culture, teaching in the Kuvi language, where children can grow up to be proud of their heritage and yet able to take on the world. On the campus here in Bissamcuttack, we also have the New Life English Medium School, started in 1986 as a department of the hospital, and today with 560 children between kindergarten and grade 10. Children who have studied in these 2 schools are now coming back to their communities, contributing back, and even working in key positions in our hospital. As a CHB family, we start our day with a prayer. The challenges and needs are far bigger than us, but we know that we are part of a larger picture, a jigsaw puzzle of transformation. Our calling is to share the pain. There's a deeper meaning in everything we do. And given our context of inaccessibility and vulnerability, we cannot but respond, stretching ourselves to become the change we need to see. And for a region in desperate need of healthcare and quality education, for people on the margins, Christian Hospital Bissamcuttack is not just another hospital. Okay.
Yeah, wonderful. Thank you. Thank you. Thank you.
I apologize for the first half getting a bit messed up, but I hope this has helped to give a little idea of what our lives are like here. This is home. I came here first as a young doctor in 1987 from CMC Vellore, just for a year, but it's become home, and it's I don't know, stagnation and dedication look the same. So I can't say which one it is, but I'm still here. Okay, so what we're going to do now is to look at the response to COVID from a hospital or a situation like this. Because most of what we hear in the press is urban-centric, city-centric kind of responses. COVID has also by and large been urban and city-centric, so that's fair enough. But that's not the whole story. So what I'd like to do is to try and take you through what we have been doing here. Again, I'm going to share my screen once more, but this time, yeah. Okay. Now, what we're going to try and, I want to try and share with you what it's been like. Working in a place where we have to continue to provide healthcare as is possible, deliveries and surgeries and stuff, because that is needed. And then a COVID situation comes in, a virus comes in that changes the agenda, but doesn't take away the original agenda. You can't walk away from the woman needing to deliver just because COVID arrived. So I'd like to try and share with you the stuff we've been trying to do, and then we'll throw this open for questions, and feel free to tear it apart. So that's what our hospital looks like from the hill behind. It's a beautiful place. People spend money to go and see places like this. We get it for free every day. So we are extremely privileged to be able to live here. So it's a 200-bedded hospital with about over 4,000 deliveries a year, over 6,000 surgeries a year, usually between 10 and 20 doctors at any given time, around 380 staff now. And this is what the hospital was functioning like prior to COVID. Crowded, overflowing, no space, that kind of a situation, but also working with education, with training, and with community health. Now, that is when COVID arrives and turns the world upside down, including our world. Now, I must confess that the amount of COVID patients or the numbers we have seen is far less than what you see in Bangalore or in cities. But for us, it is a big deal. And so I'd first like to give you some of the numbers so that you get a feel of what the size of the issue is for us. Okay, so we had to create an outpatient facility and an inpatient facility. So a fever and cough clinic near the gate, so that as patients come through the gate, they are triaged or filtered. Anybody with fever and cough goes to the fever and cough clinic, which we set up as a single window place where the patient can stay there and get their entire X-ray, blood tests, treatment, medicines, everything, payments, everything there without having to stand in queues, because the longer they stay in the hospital, the more likely they are either to give the virus to somebody or get the virus from somebody. So the fever and cough clinic has served 3,662 patients as of yesterday evening. On the inpatient side, that is the wards, between 16th of July, when our first sick patients started coming in, to yesterday, we've had 330 suspect cases in a period of 127 days. Now, when I say suspect, the issue is this: the rules kept changing. It's like you're in the middle of a football game and the referee keeps changing the rules all the time. So for a long time, we were not allowed to test or to treat. Then after some time, we were allowed to test but not to treat. And only from the 1st of September did we have permission from the government to test and to treat. And therefore, that filters the way the numbers are. But let's put this together. 330 patients have come to our hospital in the last 127 days with cough, fever, and breathlessness, what we call SARI, severe acute respiratory infection, which could be COVID, may not be COVID. Of these, 216 also had other illnesses like diabetes or hypertension or kidney problems or asthma or something. The majority were men, 2/3 men, exactly 2/3 as of today actually, 220 men and 110 women. The majority are from our own district of Raigada, and the remainder from neighboring districts. 5 actually came in from Chhattisgarh. So that's traveling over 250 kilometers to come here. There were 310 who came into the inpatient side, 205 who got admitted, 106 tested positive, including 87 in our own lab once we were allowed to test. And there were 40 deaths from among the 330, not COVID, not all COVID, only 10 of them were COVID positive. The others may or may not have been COVID. Now, if I put that same data against a timeline, and each of these time slots are 2 weeks, they're fortnights, no? So first half, second half of each month, you can see from the data that it peaked in September. That's the same time the peak occurred for our district, for our state, and for the country. The peak in the numbers, the first peak at any rate, was in the middle of September. Here too, in September, we had almost 120 cases coming to us, of whom about 77 got admitted, of whom 50 tested positive. And if you look at what's happening now in November, the second half of November, it is slow, but yesterday we had 3 positives tested. So it's still around, and we are bracing ourselves for our second wave. Our lab, which we set up, TrueNat RT-PCR lab, we set up on the 11th, but actually got permission to go full flow only from the 1st of September. We have done 293 tests, of which 87 are positive, which is about 30%, which is high, but that is because we are only testing the admitted patients, which means the more sick and more likely to be COVID patients. So if you look at the outcomes, if I take 92 COVID positive patients who've been admitted so far in 127 days, 72 of them went home well, that's 78%. 7 were sent to higher centers from where they recovered and went home, as far as we can hear from them. 3 are currently under treatment with us, and 10 died. That's 11% of the patients admitted here for COVID died, which is high. You would expect it to be around 2.5%, but that's because we get only severe patients. So in an ICU care, you expect around 50%. This is around 11% is what we have seen in our deaths. Of these, 3 died here, 3 died in referral hospitals, and 4 died en route between the places. So let me try and show you what we try to do. You must remember, we are a mission hospital located in rural Odisha with a predominantly tribal population in the region. 63% of our block, 55% of our district is tribal. We had to respond to COVID. You don't walk away from challenges, you face it straight. So we had to respond in terms of diagnosis, patient care, but also in terms of staff protection, because the stories from Italy and The stories from Italy and Spain were scaring us. But we also needed to continue to be available for regular healthcare, like conducting deliveries and emergency surgeries, because there's no way that there's anybody else who's going to be able to take on those roles in our district. So we would still need to do those things. We don't have the luxury of having separate COVID hospitals and non-COVID hospitals because the care requirements are so much more. So with that as a base, let's try and see what was the approach that we have been evolving over the last 7 months. We put down our aims as one, to reduce transmission pressure. The virus is trying to jump from person to person. The job of the virus is to multiply and conquer the world. That's its vision mission statement. Your job is to try and reduce the transmission pressure, the chance of it jumping from person to person. So our first aim was to reduce transmission pressure. And our second aim was to respond to patients as best as we can. We don't have an ICU. We don't have, fancy specialists. We have very ordinary, sincere doctors and nurses who will try our best, but it isn't like the stuff you see on television. So if these two were our primary aims, the principles we've tried to work on, the first is aiming for situational excellence and social relevance. What I mean by situational excellence is to ask yourself the question, is this the best we can do in these circumstances? And social relevance is to ask the question, will this make a difference to the poor? Because if you are not making a difference to the poor, then you're sitting in the wrong place. The second principle we looked at was participatory management and teamwork. It was very clear that if we have to deal with this pandemic at our level, everybody would have to be on board. Right across the spectrum of staff and public and everyone, because this is not something one person or two people can try and force others to do. And the third principle is to use common sense, which is actually not very common, but we have to build on what we have. There's no point sitting and mourning over what somebody in Atlanta suggested just because we can't do it here. So we said we will use common sense. So if that is the basis of the approach, now let me try and share with you the lessons learned in the process. In April, by the end of March, we had come to the conclusion that masks were the most important protection one could have against COVID. Now, I'm saying this because at that time, WHO was not saying masks are necessary. In fact, CDC Atlanta, the kind of ICMR of the USA, they were saying don't wear masks. Masks are not necessary. So at a point in time when international players and national players had not used common sense to come to the conclusion that masks would be the answer, we realized that here because there's nothing exciting about it. It's just common sense that if you had two people, one with the virus and one without the virus, putting barriers between one man's mouth and the other man's nose makes a lot of sense. So we decided at the end of March to start a Mask for All campaign. We recruited about 67 tailors in the locality, taught them how to make masks, supplied them the cloth, paid them 5 rupees per mask as a contribution, and we distributed 30,000 masks in April and the beginning of May, first covering our town here, which is a 10,000 population, with the help of a local club called AFSA. They did the distribution, and then through our community health team, covering all the villages around us. So 30,000 masks went out individually to each person in our region between April and May, and we also moved food rations to the lockdown when the weekly markets shut down. In the meantime, we were training our staff to move. The second question was PPE. And we were watching all these movies and TV shows from Italy and Spain and China where everybody was looking like they were going to the moon. It was pretty clear that one, we are not going to be able to afford sustainably that kind of PPE. Everything was going to the black market. But two, it's also going to produce a whole lot of waste. If you use disposable stuff, which at the end of the day is going to suffocate our environment. So we started doing our own thinking, led by the faculty of our College of Nursing, of making our own PPE. Yes, we got commercial PPE, we had donations from APPI and Tata Trust and others, and bought some as well. but we decided to make our own. So if you look at the mask in the picture, this is the CHP mask, which is going from ear to ear and from nose all the way down to your neck. It feels really secure. It has 2 layers of cloth and 2 to 3 layers of polypropylene in between. So the cloth on the inside absorbs the sweat. The polypropylene gives you the filter. The polypropylene basically we got from a bag factory which had shut down in Raigada. We bought up all their remaining stock and set up tailoring units, and all our staff who know how to stitch shifted over there and started producing it. And our team was examining the polypropylene under a microscope. If you wash it, what does it look like? If you autoclave it, what do you look like? Does it get spoiled? What temperature can it tolerate? So that we could reuse our PPE. Over time, we realized that contrary to what everybody says, actually what matters of personal protection equipment is what is above your shoulders. Because the exit portals for a virus are only your mouth and your nose. And the entry portals are your mouth, your nose, and your eyes. So frankly, even if you are naked below your shoulders, I'm not recommending it, but it wouldn't actually make a difference. What matters is what is above your shoulders and maybe your hands, because you tend to, scratch your nose or whatever with your hands. So over time, this is the version of PPE we've come to. These are cotton gowns that our staff are stitching. This is what I would wear when I go to work, which is only to cover our street clothes so that we don't take any bugs home with us in the evening when we go back. Otherwise, a face mask and a face shield, these 2 are your best protection in our kind of hospitals. Then we started multi-level triaging, which is from the gate onwards at 3 points. Anybody walking in would be stopped, would be asked to wash their hands, and we made masks compulsory on our campus from the 4th of April itself. Nobody is allowed to enter our campus without wearing masks. There are masks at the gate, pay 10 rupees, and you get a mask, a cloth reusable mask. We set up the fever and cough clinic, and we converted our medical ward into an isolation ward. It's the beauty of the old-time hospitals that they're all single-story, wide open, spaced out, sunlit, and far more healthy than your city hospitals. We had to plan for surges because we were watching the data and we knew that the numbers may go beyond our control. So we did surge planning. So this shed in the picture is what we call the SARI shed, partly that stands for severe acute respiratory infection, and partly because when it's not being used, all the women are drying their saris in that ward. But also on the picture on the right, you will see that in our verandas of the casualty department, we've tied oxygen cylinders so that when the patient numbers increase, we just connect them up to cylinders on the veranda and till we can find beds for them. So we did surge planning. Okay, so this is kind of things we have been doing. Now let me try and consolidate the learnings from the preparatory phase. I hope you're with me and we're doing okay. Learnings from the preparatory phase, which started on the 17th of March and is still continuing. We're still preparing all the time. The first is what is critical is leadership. To hold this together, we needed leadership and team leadership, not individuals. So we've got a 17-member COVID task force, which includes doctors and nurses and administration and purchase and finance and maintenance, lab, pharmacy, records, triage, all together. We meet once or twice a week now, and we've had 78 meetings so far since March. Everything is minuted, but this is how we plan, review, and collect suggestions and ideas from the rest of the staff. The second we found was preparing the staff team. Everybody was scared. You're hearing of friends going down. You're hearing of friends dying in different hospitals. It's so easy to get psyched out. But we had to prepare the team with repeated training sessions. And every morning, 7:30 to 8, we converted our morning chapel into a COVID update. So we start every day with a COVID update where we look at data, global, state, national, district, and our hospital, but also at what is new, what is the new knowledge coming out, and we do a daily update every day for the last 240 days since lockdown started. And then we had to reorganize the hospital into the COVID zone and the non-COVID zone, but somebody forgot to tell the virus, and so you still have to use universal precautions. That is to say, anybody may be positive, so protect yourself. multi-level triaging, that is the filtering of people coming through the gate into cough and fever lines and non-cough and fever lines, and creating an isolation ward with phase-wise expandable plans. Number 4 was, how do you reduce transmission pressure? And that's why we started the Mask for All campaign. Phase 1 was in April with 30,000 masks. We've just finished phase 2, or we're just finishing phase 2 in October, which is another 10,000 masks. So we've distributed about 40,000 masks. And in the meantime, some tailors managed to earn their livelihood through this process during lockdown as well. Moving to social distancing and crowd management, ensuring there were people in place. We had to set up waiting sheds on campus, especially during the rainy season, so that people have space to shelter far apart from each other. We had to move all crowds and queues outdoors. One of the key issues is this: transmission pressure is much higher inside buildings than outside buildings. So we moved our registration counters to the window, for example. Move the computer to the window and people can queue up outside instead of indoors. Everybody does better that way. And then, of course, personal protection equipment, in-house designs, innovations in production. We had to procure and install a lot of equipment. We had to put in an oxygen concentrator plant because our oxygen cylinders come from Vishakhapatnam. That's 250 kilometers away and across the state border. And when people are into paranoid lockdowns, you can run out of oxygen very easily. So we had to buy quite a bit of equipment and set it up. We did this because we anticipated we'd be getting a lot of COVID, and we were able to get things in place before the first patients hit us. What are the lessons from the patient care phase? 1, emergency triage. We now examine the patients inside their vehicle itself as they come in, because if they don't have a COVID-related illness, there's no use they're getting down into an emergency department where they may actually get COVID. So if you're able to assess the patient inside the vehicle, oxygen saturation, blood pressure, and so on, then you can move and let them alight where it is safe or appropriate for them. We learned that clinical skills, are critical in strategy. Excuse me. More and more, the new doctors coming out will be dependent on technology and labs. But in this business, there is so much you can do in COVID with a stethoscope. It's amazing how much you can do. We had to set up a lab for diagnosis because there's no diagnosis available anywhere near us. And if the government was taking a swab at that time, it would take us a week or 10 days to get a result. So we were able to set up a lab with TrueNat equipment so that we can get our results within an hour or 2. We had to look after the staff team, and you had to be egalitarian. You had to be even-handed. Staff will fall sick, and you cannot have a separate sick room for doctors and for cleaning staff. Everybody is part of the team, and everybody has to be treated equally and well. We had to revisit our ideas on hospital architecture. We realized that we had huge advantages in our old style horizontal spread out hospitals over these kind of modern vertical glass boxes that you have in the cities, centrally air conditioned, just right for COVID. We realized that many lives can be saved if you have oxygen. So much noise was made about hydroxychloroquine, or forget it, about remdesivir. You pay, through your nose for a drug which now they say doesn't work. Good old oxygen saves far more lives. With the basic drugs that the government of India recommended and good nursing care, you actually save a lot of lives. And we need to tell ourselves कि हम किसी से कम नहीं हैं. You don't have to mourn and say, अरे यार, हमारे पास intensivist नहीं है, ये नहीं है, वो नहीं है. That's immaterial. You have to work with what we have. And you jugaad all the way. That's intrinsic to our DNA. There's some other key perspectives I want to share with you before I throw this open. One was that we realized we had to protect and sustain the mothership. Because you can go chasing down COVID, but if the hospital shuts down, what's the point? And healthcare institutions took a huge hit because almost nobody understood what hospitals were going through. Hospitals that run only on the income of what the patients pay got hit by lockdown, just like the aviation industry, but nobody wanted to give a bailout. So there was institutional vulnerability, and this was so much more for what I call the sandwich sector. The not-for-profit, non-governmental, poor-focused hospitals and their staff have absolutely no safety net. So we had to be very careful with our finance management in April, May, June. We lost about 1 crore in terms of income at that stage. We drew on all our precious savings, but we paid all staff their full salary until the numbers picked up and we were able to break even again. At this point, I want to say we're extremely grateful to Mr. Premji and all at the Azim Premji philanthropic initiatives, because they generously reached out to us and helped us and many other hospitals like us to survive those terrible months when we needed to be out there, we needed to be caring for patients, but we weren't sure we could actually pay salaries or afford to buy the things we needed to do. The APPI really helped us all out. I don't know how many hospitals, but so many of us got helped by them at this time. We also needed to keep the cost low for the patient. The government of Odisha says you can charge up to 1,750 per day, not more than that. Our costs, oxygen and everything included without ventilators, is coming to around 1,500 to 2,000 per day, all told, including drugs and stuff. So if a patient had to stay 8 to 10 days, their bill would come to 10 to 20,000, and then we'd allow them to pay what they can. And the APPI grant allowed us to subsidize the rest of the care in between, so that the person doesn't need to sell their cow and their house to get cured of COVID. Some other key perspectives. One, we realize is our greatest asset is the team. Preparation, training, updating, providing for them, insourcing people as volunteers or on short-term contracts because we suddenly needed more hands on deck. Everybody had to be willing to multi-skill, multitask, and take on totally new roles, like the College of Nursing doing PPE or even hospital billing, the community health department doing crowd management, and spiritual nurture, because there are real fears for our children, fears for our parents. And you needed to provide nurture. You're not allowed to gather in large groups. A church and chapel had to be locked, and yet you need to sustain your team. And that was another big part of what we needed to learn. Another was trend analysis and planning ahead. We did a daily data analysis of data, global, national, state, and district, and then learning to project what is likely to happen 2 weeks from now, 3 weeks from now, and then planning out our surge spaces and surge teams in advance. And the present reduction we've seen in November has given us time and space to reflect, but the danger is that we will relax. And 3 positives yesterday, it reminds us to wake up. And the final key perspective I want to add in this was that in all this, you recognize the hand of the divine, because we have a consciousness that this is a much larger dynamic jigsaw puzzle game. And we are just part of the whole. Sometimes you can get so taken up by yourself that you need to step back a bit and see that there's so much happening all over the world. We are a small part of this, and we are not alone. There's a divine hand that has been preparing and guiding us for these situations, long before Wuhan or Bissamcuttack got the virus. For example, in 2014, the Tata Trust gave us a very generous grant to build up some of our hospital infrastructure. For 5 years, I was doing construction work, and we finished only in June 2019, just 5 to 6 months before COVID started. But what strikes me is that if COVID had come 1 or 2 years earlier, we'd have been sunk, because we were working in temporary spaces at that point. So just throwing things in the air, and I'll stop there. Fire away. You can ask any questions you like. Politeness limits learning, so ask anyway. Let me try and get out of this thing without destroying my computer. If I figure out how to do this, I have to stop sharing. Is that right?
Yeah, I mean, it's absolutely amazing, Dr. Johnny, and I was thinking of something like this only from you. As I said, some of us were, not now we're volunteering for the COVID response work in Bangalore, and we have seen hospitals' responses. And as you said, that in cities at least, they may not have resources, they can manage lots of things here, but some of the philosophical decisions that you had to take, they were quite amazing. So I would request the audience to type their questions in the chat box. But meanwhile, let me begin, since I'm in the moderator's seat. Let me begin with, okay, there are certain questions. Some just go with them. And then I can ask you something which I wanted to ask you later. Yeah. And my colleagues will help us in projecting the questions. Yeah, Bakul and Pravina, you can display the first one that we have got. So this is from my colleague only, John Korean. So he has asked what lessons are learned about health for the future of the tribal communities from the pandemic experience.
And I think somebody else was also asking how the community understood COVID, assuming that there are, so let's just pick this up. Now, in the whole issue of tribal health, part of our problem is that we are stereotyping the tribal community. I'm on the scientific advisory committee for the ICMR Center on Tribal Health, for example. And by and large, everybody thinks that health issues of tribal people are only malnutrition, TB, and malaria, and sickle cell anemia for some funny reason, which is not true, because the tribal community is just like us. They also have kidneys and livers and hearts. And if you ask me today, in the community I work with, the single commonest diagnosis or illness or disease among adult male tribals is hypertension, high blood pressure. The commonest cause of death in the 53 villages we work with has been for the last 4 or 5 years, chronic kidney disease, kidney failure. There are a lot of myths in the tribal question. And therefore, we are looking backwards and thinking and trying to run forwards. So I just want to say that the comorbidity question in COVID alone, if you are thin, young, and don't have diabetes or kidney failure, it doesn't matter so much. But those who get into trouble are those who are fat, have large stomachs, have uncontrolled diabetes, or have kidney failure. At least in our data set, that's the 3, even more than age, which actually predicted bad outcomes. Now, of the COVID patients we saw, it was far less among the tribal community than among the non-tribal community. And I think that is partly because of the nature of the virus, the nature of the transmission process. Outdoors is far safer than indoors. Now, what we found is, when we were telling people, when you come out of your house, wear a mask. Inside your house, you take off the mask. But if somebody in your family has COVID, you asked for it. Because transmission is much more, much higher indoors. But for a tribal community in our villages here, the whole village is like your house. You don't live in your house. The house is where you keep your things. You live in the community space, on the veranda, in the outside. And that's terrific to reduce the pressure of transmission. So if you look carefully, you will see some of the issues. So specifically on where does the future lie, we were so scared that the community will land up. Yes, we've had a few COVID positive patients among the tribal community, but far less than among the non-tribals so far. What are going to be the implications of the future in tribal health? I just hope that the policymakers will open their eyes, get off their armchairs, and get down to the ground and understand that the tribal community has moved forward. Our understanding of the tribal community is still 20 years behind time. So I think for tribal health, we just need to be being realistic and work with the community diagnosis, the priorities based on morbidity mortality data, and then face those. The ultimate aim is health for all, that everybody is able to live fully productive, happy lives. Tribal communities have an advantage on some issues on that, disadvantages on some, and we just need to tweak that circumstance. I don't know whether that answers your question, John Korean, but something.
Yes, Pravina, we can go to the next one.
Can I'm also seeing the comments and questions coming in here.
Yeah, but I thought that if you display it, then the audience can read it. Pravina, can you do it? Okay, I think that here's some network issue.
Okay.
So we can just read it aloud and you can start.
Sure. Somebody called Giri Rao.
Yeah, he's again a colleague at university.
Okay, that's a very good
Because
question.
many people may not, if they are logging in from mobile, sometimes they don't see.
Sure, sure.
Giri has asked, is there a larger public health message for us as a country? I think you have partly answered, but
Absolutely. Absolutely. See, the last time I saw anything like this was when HIV came in, right? I'm not saying these are good things, these are terrible things to happen. But HIV forced us in health to change so many things we do. Things we should have been doing anyway. If you look at, in this region, when government hospitals did tubectomy surgeries, family planning operations, by and large, they were being done barehanded till HIV came. We should never have been doing barehanded surgeries, but HIV forced us to wear gloves. HIV forced us to ask a patient's consent before we do something. HIV forced us to say counseling is necessary in medical work. So among all the terrible things HIV did, HIV also shook the health system into waking up and correcting many deficiencies in our system. COVID is doing the same thing. COVID is shaking us up to a point at which we should have been washing our hands anyway. Right? We should have been looking at infection prevention and control in our hospitals anyway. We should have realized that only the public can achieve public health. It cannot be done with, by a doctor or a hospital. Only the community. Without the community, there is no community health. Without the public, there is no public health. And COVID is such a good example that unless you're carrying the community with you, there is no way you can achieve control. Or, countries like New Zealand and Taiwan show us that so clearly. And even if you look at the leadership of the countries which have the highest numbers as against the leadership of the countries which have got a control on COVID, one, there is a gender difference between the two, but there is also a commitment to public health, a commitment to consensus, a commitment to dialogue, because public health has to run on the backs of people working together. So I think there are huge lessons for public health in our country in COVID. Once the emergency phase is over, we have to learn those lessons or we are condemned to repeat our mistakes.
Bakul, you can display. Yeah. Abhinay has asked, what challenges you faced when you were spreading awareness on COVID-19? So I would just like to add something to, on this question, Dr. Johnny, because we have also worked in Bangalore for spreading awareness in largely urban slums. And mostly the way they saw COVID, or for them, COVID was not a medical disease, it was a lockdown problem, it was a livelihood issue. Because they lost their livelihood and income because of the disease, which is not affecting them, according to them, directly, right? So in this tribal villages, when you started going, and I'm sure that your team was trying to do something about spreading information about COVID. How did it go about? I mean, how did they understood it or misunderstood it?
Okay, so sure. So let me take this in two halves. The question from Abhinay as well. Let me just break this into two parts. The first is to say, what do people really need to know about COVID? You have to boil down the message to the non-negotiable parts, the essentials. Excuse me, sorry. You also need to communicate it in a way that everybody can understand. No, communication models are very different in different communities. Humor is very cultural. Now, let me just share with you the way I explain it to people. It's very simple. The local police station asked me to explain to the police, because police were a very high-risk group, because they had to be out there on the front lines all the time. And many policemen became positive because what to do? That is, their duty forced them to be on the front lines. And so when the local police asked me, can you please do a session for them? I did. Now, let me just explain. Whether I'm doing this in a village or in a hall, this is how I explain this. Here are two people. Okay, can you see this? Yeah. This is Ramu and this is Dasu. Okay, so Ramu and Dasu. Ramu has got COVID. He's infected with virus. Dasu doesn't have it. Now the question is, how does the virus go from Ramu to Dasu? Now, the only exit portals Ramu can release the virus only through his nose and his mouth. When he coughs, shouts, sings, talks, even breathes out, sneezes, the virus is being sprayed. Daso can take it in only through his nose, his eyes, and his mouth. If it directly falls on him, or it's hanging in the air and he breathes it in, or he gets it on his hand and he goes and smashes it onto his face. So this is Ramu with the virus, this is Daso without the virus. So what is the way, what can Daso do not to get the virus? A, it depends on the distance. The closer you get, the more likely that Ramu can pass it on to Daso. So if you get 6 feet apart, you are unlikely to get it. So you pull this thing, wherever possible, stay 6 feet away from the next person, wherever possible. Similarly, outdoors, when Ramu coughs outdoors, it gets spread all over the place. When Ramu coughs indoors next to Daso, the chance of crossing is over. So move as much activity as you can outdoors. 3, Ramu can cover his face or with a mask, so that even if he coughs, it doesn't go. And Daso can also wear a mask, so that even if this guy coughs, it doesn't get in. So it is more important that Ramu wears a mask than Daso, but we don't know who is Ramu and who is Daso, so everybody wear a mask. And 4, wash your hands, because if Ramu has sprayed it out and Daso got it on his hands and then spreads it on his face, he gets it. So I know it doesn't work so well on a TV screen, but when you do this under a tree, it's amazing how quickly people catch the message. And you play your hands. See, tribal communities are very visual. When we use picture language, we don't, when you 2.5% of the population may die, they want to know who's that half fellow. It's any sense to you, right? So you learn to communicate in an idiom that is easy for everybody, and it quickly picks up. So once you've got that, so you have to convey the message in a form that people can easily absorb. That's the first part I want to do. The second part of the story is how do you motivate people to do things? Now, I'm not going to get into the politics of was the lockdown right or not, livelihood versus health, life. It's a debatable one. Somewhere the balance between the two can go wrong, and I think we got it very wrong. But what to do? People had to make decisions based on what they knew at that point in time. But for the individual, it was important, if you say fear in the right dose. Not too much fear that paralyzes you, not absolutely no fear that makes a fool out of you and you go and pick up the virus somewhere. So even this morning to my staff, this is what I said. We need fear in the correct dose. Enough fear to take steps you have to take, not so much fear that it paralyzes you from getting. That's another part of the equation. The methods you use can be many. TV, and you're sick of listening to the phone. Every time you try to phone somebody, you lose another 10 seconds, 15 seconds listening to that same thing again and again. But these are multiple methods in which you try getting the message across, and you have to keep changing the method because people tire of any method very quickly. There's a fatigue which is occurred, which is fair enough. People are tired. In between, there was a big rumor which went around in our community that there was no corona. It was just made up by the government because they get money for every case. So then we had to go around telling people, no, that's not true. So-and-so, he also had it. So-and-so, he also had it. That person died. Do you realize it is here as well? So we had to periodically do that as well. I hope that's useful.
Yeah. Thank you. Bakul, next question you can show. Okay, I think Dr. Assis, I'm very glad that another public health practitioner, and he's working in Melghar. Dr. Assis is here. I'm sure you know him. So he's asking, what was the transmission rate among your staff?
Okay. We cheated. Let me tell you, we cheated. We didn't test any staff. Okay. The reason is this. If any staff or student of our hospital has the slightest fever or cough or sore throat, they have to get admitted and isolated. Why do we test? So that you can treat. You treat syndromically. There's a paper by Dr. Jacob John and Dr. Seshadri on this. You treat syndromically because you know, for us at that time, the testing, the results were taking 10 days to come. It's very irrelevant. You would have to treat, if you thought it was COVID, you treat it as COVID. Because even the tests you have, antigen tests give you maybe between 35 and 50% sensitivity. Your false positives are more than your true positives. Even a RT-PCR gives you only a 70% sensitivity. That means 30% of those with the virus will still come false negative. So you still have to use your brains. You can't outsource your brains to the RT-PCR machine. So what we decided is that, if we suspect COVID, we treat it as COVID. It's far safer than missing and losing a person. 2, if you think they have COVID, then they have to be isolated so that they don't spread it to anybody else. And you look after them well. We blocked one private ward so that any staff who had the slightest cough or cold gets a single room with a bathroom and a kitchen attached, and food will come from the hostel, and they're well looked after. So by doing this, 2 things happened. 1, I know that maybe around 60, 70 staff would have got admitted, I think, maybe more. I haven't looked at the numbers. For cold cough, maybe some of them were COVID, maybe some of them were not. They all got treated. Nobody became too sick. A couple of them needed oxygen, but nobody went beyond that stage. They all got well and everybody went home fine. On the other hand, we don't have data to say how many got positive. At that stage, the government was into a knee-jerk reflex that if any hospital got any positives, they would shut down the hospital. That was the policy at that stage. And that was absolutely irrational, because if staff don't get positive, who's going to get positive? So looking at all this together, we decided that we're not testing. Unless a person got really sick, we wouldn't test them, the staff, but we would isolate and treat every one of them and make sure they're well. Now, in retrospect, what we are doing is we are doing antibody studies on all the staff who had fallen sick. In retrospect, we will know how many of them probably had COVID. And I think that will be quite a number. Our argument is also that because of the masks we're wearing, our masks are very, very good. If I put mine on, this is the mask we're wearing, right? This is polypropylene with cotton inside, so it's comfortable. And I'm wearing this. Our theory is that the amount of virus we get is probably far less, that you're decreasing the viral load using good masks. So I'm sorry, Dr. Ashish, I'm not able to tell you numbers of staff infected, but I know that I think less staff fell sick during the last 7 months than in normal years. Other illnesses came down. And I think the masks actually saved a lot of asthmatics and other respiratory infections as well. So we don't know. We'll have to look at the data. We'll have to stop running to look at the data, actually.
In fact, Dr. Ashish has commented just
Sorry.
they experienced shutdown in the hospital because 3 of their staff became positive.
So this is a totally irrational policy.
Yeah.
The poor hospital staff are standing. You shut down the hospital. What good does it do to man or beast? You have to isolate those staff. But you have to get on, because otherwise people will die of deliveries. There will be maternal deaths. If you shut down a hospital like ours, there will be maternal deaths. See, it is like asking a man, you're going to die in a road traffic accident. Would you prefer a bus or a truck? What's the big deal if you're going to get hit? So, you have to take a look at the larger perspective. For us, the end point was that people who come to us must go home healthy and well, and even the people around us must not be put at risk because of us. So we converted our guest house into quarantine for staff. We converted a private ward into isolation ward for staff who had any cough, cold, fever, get admitted. Play safe. We want you safe and well. We will look after you, and we don't want you infecting anybody else in the process.
So Bakul, you can share the next question. So it is also kind of linked to the earlier one from my colleague Arima. How did you then sustain the motivation of the staff?
Yeah, so this is even in normal times, that is not easy. Hi, Arima. Even in normal times, it is not easy to sustain motivation of staff because we live in a world in which, one can go up and down all the time. So even normally in our hospital, we expect all our staff to be internally motivated. We run on trust. We don't police our staff very much. We make mistakes, we mess up sometimes, but by and large, if you run on trust, you save money. And no, I'm not only quoting what's his name, Covey, Stephen Covey, but I'm saying that trust actually saves money. Trust motivates. That is on one hand. But in this situation, our primary tool of motivating people is group meetings, morning prayer, chapel, that spiritual nurture. That tool was taken away from us because crowds and especially singing can be extremely dangerous in the context of COVID. So you are removed, your normal props were removed. So this had to move into smaller group. It had to be done smaller group. It had to be done online. But by and large, our system is still a very face-to-face, person-based kind of a system. So I think most of our staff had to draw on their own inner strengths. There were times when it got really tough. August and September were really, really difficult, but we kept telling our staff, we are here for a higher purpose. This is what we were born for, and the staff knew that if anything went wrong, they would be looked after because the slightest illness, and we were all there to look after each other. So little things like that is what has sustained us so far. The second wave has not yet come, so I can't talk too fast. But for me personally, I had to move back to clinical work after many years because at this point in time, we were actually very short of doctors because a number of our junior doctors got in for postgraduate courses, and we suddenly went down from 22 to 13 in the first 2 months of lockdown. So all of us had to, multitask, multi-skill, and jump into the fray. So, and our rule also is that when there is danger, the seniors must stand up and be counted. You don't send the juniors into the front line. So we were there right up front. Dr. Sunil, Dr. Hema, all of us, the seniors, took on, when there is a cesarean section, an operation for delivery which had to be done for a COVID positive woman, then the senior most doctor does it. That's part of our culture. Seniors eat last when we have a meal. That is part of our culture, the way we work. And so those things have stood us in good stead. What I'm trying to say is, crisis will reveal character. Crisis does not create character. If you don't have character before the crisis, you're unlikely to find it suddenly during the crisis. So we need to use our normal times, our peace times, to build capacity to cope with crisis. Otherwise, when the crisis comes, you just sink without a trace. So I think we were very fortunate because our staff are very, very good. And I mean, even their response during COVID surprised me as well. It's amazing how much they stood up and took the thing far more than even I had expected. But lots of communication, lots and lots of communication.
So Arima has commented that it's very useful point. You were talking about the inner strength, the supporting each other, and communication. Yeah. So thank you. So Bakul, we can go to the next one. Sanjana, I'm sure you have met her.
Yep. Yeah.
She has seen, so they have been documenting stories from ASA workers, ANMs, frontline health workers, and they found that most of them were facing challenges implementing social distance norms and quarantine for migrants and so on and so forth. So what is your experience? How did your staff?
I'm also part of a group of mission hospitals like ours, About 100 hospitals are on a WhatsApp group, which came to life. It was there earlier, but COVID, gave us a far greater reason to learn from each other. And so there are hospitals where staff could not go home, where staff were thrown out. Hospital staff were not allowed to return to their streets. They were asked to resign or get divorced. There are many places where staff and their families faced a lot of hardships. Our town was very good. We have not faced that kind of any discrimination. Yes, I got a few threats. You are bringing COVID into our town, kind of a thing. But that's just lunatic fringe. By and large, the public has been good to us in the COVID epidemic, better than normal times. I think there's a lot of Odisha government has been very, very good in supporting healthcare workers by and large. This is my impression. But having said that, obviously that cannot be the experience of everybody. And the ASHA is the bottom rung, gun fodder. So when you send an ASHA to go house to house asking, is there anybody with cough in this house, armed with nothing more than a mask, you are asking for trouble. So yes, it was a tough, I think the government had very tough decisions to take. On social distancing and quarantine, I would just always say goals are more important than methods. Okay, sometimes, especially in our development sector, we become very possessive and proud of our methods, and they become our goals after some time. And then, even when the goal has become irrelevant, we still force everybody into our methods. So that's why I keep doing this Ramu and Daso story. The aim is that Daso doesn't get a virus from Ramu. Social distancing and quarantine are only some of the methods that help that to happen. Our job is to reduce transmission pressure. So again, social distancing and quarantine must be used as tools, not as masters. Right? So for example, an air-conditioned conference hall with social distancing is still far more dangerous than a tribal gathering under the trees.
Yeah.
Now, the problem is the methods have taken control of our thing. That's why I keep saying use common sense. Think like the virus. Try to understand the psychology of this virus and then say, how do we turn it around? So if you're able to do that, then I think you can get around these issues. There is no doubt social distancing is important, quarantine is important, but not absolutes. These are not absolutes. You have to allow the science to speak and not get so carried away with the formula 1, 2, 3, 4 that you forget what the reason why you're doing what you're doing is. I always tell the story of the fellow who got on a train. He wanted to go from Bhubaneswar to Bangalore. So he found out there is this particular train that goes, but he'd never been on a train before. And so somebody told him, you want to go to Bangalore, take the train. He took the train, but once he got on the train, he found the experience of the train so good. So, it was going chadak, buduk, and it's shaking. It reminded him of his mother, shaking him in his arms when he was a baby. And the chai comes with you, and even the toilets come with you. He was so fascinated by the train that when it reached Bangalore, he didn't get off. And 20 years later, he's still on that train going between Bhubaneswar and Bangalore because he couldn't remember why he got on. This is what happens to us in public health. We get so married, committed to our methods that we forget our goals. So I would say keep questioning those methods. And I'm not saying throw away the method, but use the method only insofar as it fulfills the goal.
Yeah. So, Bakul, you can, yeah. Yeah, so John has again asked how are institutions important for the kind of work that we need to do in society?
I think education institutions are extremely important, not only for the period of time the student is with you, but for the hand-holding and accessibility subsequently. Because education doesn't stop with a degree. It goes on and on. I'm very grateful to CMC. It was not just my college. That's where I grew up. My dad was the chaplain at CMC. I grew up there. That's where I did my schooling, my home, and I've seen CMC from many, many angles. For For me, the education in CMC, relatively, if I ask, what did it give me extra? Many, many things. One, I think, is the willingness to get mud on your hands. Not scared of cleaning the drain or carrying a chair or doing the stuff that needs to be done. Your degree mustn't limit you. Your degree mustn't define you. And I think in CMC, as not part of the education, but because of the life we lived, part of our job as students was to wash dishes and carry chairs and stuff like that, which is part of training, which I think is essential for a good doctor, not to be scared to push the wheelchair or whatever. So I think that the dignity of manual work. I think another is the ability to think, to logically think through a diagnosis and not jump to conclusions. I'm not saying other medical colleges don't teach that, they do. I think value systems, some may be very useful. Another one I would say is the value they put to community health. My postgraduate training is in community medicine, and I like the word community health better. In PMC, you can do community health and be proud of it. Most people tell me, "Arey yaar, you look too intelligent. Why did you do this subject? How kuch seat nahi mila kya tere ko?" Whereas in CMC, you could do this thing and you could go off and work in some godforsaken place and you get celebrated for it, not looked down on for it. So there are some things which definitely are good, but there are so many good places, and I don't think we have proprietary rights on what is good in medical education. But yes, I would say, if not for CMC, I may not have ever seen this place. I got sent here by the principal in 1987 for 1 year. We have a rule, 2 years of service after MBBS where you're posted. And I got sent here for a year in 87, and I fell in love with the place. And so I'm grateful for that exposure.
Thank you. So I think we are almost about time. So let me finish by asking one last question, which is almost everyone is talking about it. How does winter look like for you? I mean, what is your kind of prediction, if I may use the word? Because you are also analyzing the numbers, I know.
Yeah. Okay, if you remember in April and March and February, the predominant theory going the rounds on social media here was that India will be protected from COVID because our temperature is better than theirs, this black and white question. So it obviously wasn't true, because summer also there were a lot of cases, and India's numbers are second highest in the world. So USA, for all sorts of obvious reasons, and India corner the majority of the COVID cases in the world. So did summer decrease COVID? Maybe, not totally, to some extent. So then can winter increase COVID? Maybe. So one thing is the weather angle to it, but there is also an obvious cycle in the waves that are moving. So if you look at the Indian numbers, we rose to our peak in September. At one point, 97,800 cases in one day was the top number, I think around September 16th or something like that. And then it started coming down. You always take numbers with a pinch of salt, but then that pinch of salt is constant. So the trend is still valuable. The absolute number may not be. And the fall occurred. But if you look at the data now, Kerala and Delhi, which are the ones which went down first, went up first, went down first, are now breaking all the records possible for their size. Whereas Karnataka, Tamil Nadu, Andhra are sitting around 1,500 a day now. Even Maharashtra has come down from their 15,000, 16,000 to today's is 5,000, or yesterday's was 5,000. So if you look at these numbers, I think the second wave will come, and winter may make it worse. Even without winter, I think it would have come.
Yeah.
But winter might make it worse. Now, I'm not the expert on this. I'm just a village boy who likes to pontificate. So, but my bet is that yes, December might be worse than November and October. And if you look at the second or third, Delhi is calling it a third wave. at least the media in Delhi calls it a third wave. The second or third wave, whatever we want to call it, is far higher than their first waves. And this has been true everywhere. Italy, Spain, France, Germany, all their second waves are looking worse than their first waves. And yet you see countries like New Zealand and Taiwan, and even Germany, who seem to have done a far better job than some others. So I think in India, we are sick of it. The public is sick and tired of COVID and of lockdown and of everything. And so I don't think they're going to respond, I think, as the markets in Delhi show. They're not going to respond if you tell people to stay home. I don't think that's possible anymore. So the second wave, I think, will be far worse than the first wave. But we just need to get ready. But now we know more and we're better at managing it. So I think deaths may be less, even if cases are more.
Yeah, I mean, from my experience of Bangalore, I think the hospitals are now quite well prepared. Government also knows the strategy. The testing capacities are increased, and I think that we are better prepared now. Even if public is little opening up and the economy has to run, somehow we may be able to manage it if you remain alert.
I think as much of activity as possible should be moved outdoors. Even economic activity. If you look at ventilation of the sites of economic activity, even that, the ventilation and opening outdoors, I think, will actually reduce transmission pressure. We can't stop living for fear of dying. One has to be. But if one can tweak the circumstances in which we work, so wearing masks and even face shields, I think, are a good idea. Mask plus face shield, a plastic transparency, OHP transparencies also will do. With a mask, if you are forced to work within 6 feet of each other with people who are sick, fine. Otherwise, move it outdoors. I think we need to tweak the way we work rather than, so here in Bissamcuttack, the police, after our discussions, advised every shop to tie a bamboo pole in front of the shop so that customers don't go inside the shop. So things are inside the shop and the shopkeeper and the customer is outside the shop. Little things, common sense things, I think, can reduce transmission pressure.
Exactly. Thank you very much. And so we'll conclude now. Thank you. Thanks to all the audience and very nice questions. As I said at the beginning, Dr. Johnny, that it would have been indeed a pleasure to have you in person or meet you in person. But hopefully next year we'll meet.
When I was talking to Rishi in APPI, in April and May, I kept saying, if we survive, we'll meet in November and all that, because of that.
So we have survived, but we could not meet in November.
Somebody will think that was my fundraising tactic. No, it wasn't. Honestly, we didn't know whether we would survive till November. And my wife and I had this talk, about, okay, if something happens to us, everybody's preparing their wills and all. Because at that stage, that's what it looks like. In retrospect, we can laugh. But Upar wala to hai.
So let's hope for the best, and would like to see you in our campus very soon. Thank you.
Sure. Thank you so much.
Thank you.
Everybody.
Thanks to my colleagues, Bakul and Prabina, who are supporting us from behind. We can see them. So thank you, and I wish all the audience a very great, happy weekend. Thank you.
Thank you. Take care, everybody. Thank you.